So what is meant by heart blocks? Anybody? So it's a problem with the initiation of the current or the traveling of the current in the conduction system. Where does the current start? It starts from the SA node, travels through the it travels through the atrial conduction system. What is the atrial conduction system? It is the atrial muscle, or there are specialized pathways. There are three conduction pathways which connect the SA node with the AV node. These are called Beckman, Wenckebach, and Thorel. They connect this with the AV node. AV node is followed by the bundle of His, then its branches, and then fascicles of the left bundle. So this is our His Purkinje system. Now we see a case vignette. A 70-year-old male presented with episode of lightheadedness for last few weeks. Today he had a fall and sustained mild injury on the elbow. The attendant reported that his face turned pale and he was conscious when he was assisted to move to bed. Now what is this we discussed here? It's a fit or a faint. Now look at the ECG of this patient. What does this ECG show? What does this ECG show? It's a slow heart rate. You see the ladies. So you see this is an abnormal thing. These complexes are complete. You can see the P wave, QRS and T wave. And now you don't find anything in this. So there is a sinus bradycardia with a sinus pause. This is sick sinus syndrome with the SA node. Now what is sick sinus syndrome? Chronic dysfunction of the SA node. It can result in chronic severe bradycardia, sinus pauses, sinus arrhythmias, complete sinus arrest, progressive development of atrial arrhythmias like atrial flutter, atrial fibrillation, atrial tachycardias. Patients are usually elderly and present with lightheadedness and or syncope, sometimes manifesting as angina, shortness of breath, and palpitations. So these are the usual presentation of sick sinus syndrome. It is number one, there is slow heart. It can present with syncopal attacks. The patient can have even angina and palpitations. And about 50% of the patients with sick sinus syndrome display some degree of dysfunction of the AV node as well. So sick sinus syndrome is actually, in most of the cases, age-related degeneration of the SA node. Since when there is age-related degeneration, there is age-related sinus degeneration, AV nodal degeneration can also run. So you can have problem in the other parts of the conduction system as well. Now these are the more common causes of SA node disease, like sinus node fibrosis, atherosclerosis of the sinus node artery, congenital heart disease, excess vagal tone, drugs. It can be familial infiltrative diseases like sarcoidosis, pericarditis, Lyme disease, hypothyroidism, rheumatic fever. So you see many diseases can produce sick sinus syndrome, but generally it is most common is the age-related degeneration in the SA node and other parts of the His Purkinje system. Now, the case, a male is being evaluated for insurance purposes. He is asymptomatic. General physical examination was normal, and we see some abnormalities on this patient's ECG. So, patient is otherwise normal, no symptoms. Examination is unremarkable. So this is a normal person and there is an abnormality visible on the ECG. Now what do you see on this ECG? Any abnormalities on this ECG you can find out? The patient is, in fact the person is normal, is not a patient. It's perfectly normal. What do you see in this ECG? Anybody? You think the T wave is prominent? I think this is a normal T wave, perfectly normal T wave. What you see is a very long PR interval. So there is prolonged PR interval which is constant, it's not changing. All P waves are conducted. So all P waves which are generated at the S node, they are conducted to the ventricles. But the PR interval is long. That means there is a delay in conduction from the SA node to the ventricles. This is first degree AV block. So first degree heart block is when all impulses which are generated at the SA node, they cross the AV node and reach the ventricles. There is a delay, so the PR interval becomes prolonged. PR interval is more than 200 milliseconds. All impulses reach ventricles. Patients are generally asymptomatic. Patients only become symptomatic if they have structural heart disease. For example, if they have heart failure, if they've got abnormal coronaries. Because of the delay in conduction, that can result in dyspnea, weakness, and dizziness. But in normal hearts, this does not cause any symptoms. So the patient can have dyspnea, weakness, or dizziness. It is usually caused by structural disease of the AV node, very high vagal tone, beta blockers, calcium channel blockers, and digitalis. These can cause problem in the conduction of the AV node. Prognosis in heart failure is generally poor, but is all right. Not have structural heart disease. This is not a problem. Now another case, Mary. A 60-year-old male presents with fever, joint pain, skin rash, and headaches. A diagnosis of Lyme's disease was confirmed. What we see in this ECG? You see there are multiple P waves. The QRS complexes are less, P waves are more. ये T wave है, this is P wave, this is P wave. Now this P wave, this QRS doesn't have a P wave here. It's a very long PR interval. This P wave does not have a QRS complex. This PR is smaller than this PR. So the PR is variable. More P waves than QRS complexes. So this is second degree heart block with 2-1 conduction. There are 2 P waves, 1 QRS complex. It can be 3-1 as well. So this is second degree heart block. It means some of the waves which are generated at the SA node can cross the AV node. In first degree heart block, all cross AV node. In second degree, some cross, others do not. And in third degree, none of them crosses. So this is the difference between first, second, and third degree heart blocks. In first degree heart block, all impulses generated at the SA node, they cross AV node. In second degree heart blocks, some of them are in third degree heart block, none of the impulses generated at the SA node can cross the AV node. So that is the difference between first, second, and third degree heart blocks. Now second degree heart block, some of the impulses generated at SA node, they cross the AV node. Patient can be asymptomatic, patient can be symptomatic, there can be palpitations, weakness, lightheadedness, syncope. If the block is more severe, for example, if there are 3-1 conduction and patient also has structural heart disease, patient can be symptomatic. Patient may have bradycardia, there may be regularly irregular beats. Now second degree heart block is actually of 2 types. Now what do you see in this ECG? Anybody? Yeah? P के ऊपर नहीं deformed नहीं है, गौर से देखो. This is a P wave, this is also the P wave, this is also a P wave. You see PR interval is increasing and a beat is missed here. ऐसे ही है ना? You see, this is PR interval in this beat, then this PR interval elongates further, prolongs further, and then a beat is missed. So this is called Mobitz type 1 second degree heart block. It's also called Venke-Beck phenomena. Mobitz type 1, progressive prolongation of the PR interval until a P wave is not conducted. And as the PR interval prolongs, the RR interval actually shortens. So this becomes shorter and shorter. The PR elongates, this becomes shorter and shorter. And now you've got another ECG, you can see more P waves than QRS complexes. This is Mobitz type 2, constant PR interval with intermittent failure to conduct. It's a 2-1 or a 3-1 conduction defect. So this is Mobitz type 2, second degree heart block. So don't confuse, second degree heart block has two types, Mobitz 1 and Mobitz 2. So this is second degree heart block. Second degree heart blocks, Mobitz type 1, it caused by high vagal tone, degeneration of the AV node blocking drugs, Lyme's disease, myocarditis. Mobitz type 2, similar problems, His Purkinje system degeneration, coronary artery disease, valve surgery, myocarditis, infiltrative disorders, hypothyroidism, Lyme disease, neuromuscular disorders, AV junction ablation, ankylosing spondylitis, Ritter syndrome. Then you got another case. A 65-year-old female presented with intermittent syncopal attacks. She was a poorly controlled diabetic and sustained an anterior wall myocardial infarction 1 year ago. Now, what is this ECG? There are multiple P waves. This is a P wave superimposed on ST segment. This is a P wave. Now the P waves are related to each other. You see the distance between these P waves is similar. And the distance between the QRS complexes is similar. In relation to QRS complex, the other QRS complex are placed at similar distance, while the P waves are placed at a similar distance in relation to each other, but they are not related to one another. R waves and P waves are not related to each other. So there is no relation between QRS complexes and the P waves. So there is dissociation between P waves and QRS complexes. So this is AV dissociation. What is AV dissociation? Is third degree heart block. Atria are running at their own pace, ventricles are running at their own pace. So this is third degree heart block. No relationship between P waves and QRS. Relatively constant PP interval and RR intervals, greater number of P waves than QRS complexes. So this is third degree heart block. When you get third degree heart block, what will you do? So now what will you decide? You got this third degree heart block. What will you now do? Yes? When would you put pacemaker? You have to tell the next step. I would look for this. If this is there, I would put in pacemaker. Otherwise, I would do this. So this is clinical implication of your theoretical knowledge. What are the causes of third degree heart block? Yes. Lung disease is one. So then definitely you are going to answer that I would look for this. What are you going to look for this? So for that you need to know. No beat generated SA node reaches the ventricles. Patient may have fatigue, dizziness, lightheadedness with concomitant structural heart disease, heart failure, weakness, chest pain, confusion, syncope. So you would like to have, with ECG, you would like to have this history. If the patient is stable, put a pacemaker. Because there is one condition called congenital heart block. So you have congenital heart block. Patients are asymptomatic, do not generally require any treatment. So you are not going to treat the ECG, you are going to treat the clinical situation. What's the clinical situation? It can lead to asystole and cardiac arrest and all. Now you see it's caused by AV nodal blocking drugs, ischemia and hyperkalemia. So you will rule out the use of drugs on beta digoxin or other antiarrhythmic drugs. I would check the potassium. If the potassium is high, I would correct hyperkalemia. The block will automatically reverse. If there is acidosis corrected, that will reverse. So the answer would be I would look for these. And if this is abnormal, I will do this. If this is abnormal, I will do this. This is how you have to proceed. So cerebral causes cardiomyopathies, anterior wall MI, cardiac surgery, ablation, septal, alcohol injection, neuromuscular disorder. So the answer would be I would like to see what's the clinical situation. What the patient is, number one, vitally stable or patient is unstable. If the patient is stable, you're not going to pace immediately. You're going to look for the reversible causes. If they can be reversed, pacing is not required. But if the patient is unstable and there are irreversible causes of heart block, going to put in a pacemaker. Now we got from the AV node, now we come to the lower portion, the bundles. There are two bundles, right bundle and left bundle. So you can have bundle branch blocks. The first requirement for any bundle branch block, it is left or right. It should be broader than 3 small squares. So 120 milliseconds. If it is 120 milliseconds or more, this is a bundle branch block. We decide later on this is a left bundle branch block or it's a right bundle branch block. For both, the minimum requirement is the QRS complex should be broad by about 120 milliseconds or more. There is M pattern in V1. Chest lead V1 shows upward deflection, an M pattern. V1 and V2 show an RSR pattern. This is M pattern. There is an R wave, there is an S wave, then is an R wave. Lead 1 and lead V6 show broader S wave. Now lead 1 and lead V6, there is a downward complex. S wave is a downward complex. R wave is an upward complex. So lead V1 shows an upward complex, lead V6 shows a downward complex. The S wave is broader than the R wave, and the S wave is usually more than 40 milliseconds. It's quite broad. So see this one, and then lead V1 shows a long R wave peak, like that is what we saw the ventricular activation time. Ventricular activation time is more than 50 milliseconds. In lead V1, it is normal in V5 and V6. So this is right bundle branch block. For simplicity, just remember, yes, if a patient has a broad complex, this is bundle branch block. V1 shows an upward deflection, is right branch block. And you see, this is right bundle branch block. This V1 is showing a broad complex with an upward V wave. You can see this deflection is slightly, the R wave, instead of being straight up, it's slightly inclined in this direction. So I mean it is the activation time for ventricular is more. Then you got left bundle branch block. QRS greater than 120 milliseconds. There is a W pattern in V1, but usually it's a QS pattern. R wave generally is not seen, you see a QS wave. So in V1 there is a downward complex in left bundle branch block. In the right bundle branch block, just lead V1, it's an upward complex. Dominant S wave in V1. Broad monophasic R wave with absent Q wave in lateral leads like 1 AVL, V5, V6. So the lateral leads, they show Q waves. They're downward complexes. So it's easy to remember lead V1. If it is positive, it's right bundle branch block. It's negative, it is left bundle branch block. Ventricular activation time greater than 60 seconds in lateral leads, V5, V6. This is left bundle branch block. You can see V1 showing a downward complex. A broad downward complex in V1 is left bundle branch block. Now you can have fascicular block. Left bundle has two fascicles, the anterior fascicle and the posterior fascicle. So it can be anterior fascicular block or posterior fascicular block. It's called hemiblock. Anterior hemiblock and posterior hemiblock. Now in anterior hemiblock there is left axis deviation. First thing is the complexes are usually broad, but main important thing is they have left axis deviation. And then there are a few more things to remember. Lead 1 and AVL, these are lateral leads. 1 and AVL are left-sided leads, lateral leads. They show Q Rs. The small Q wave is a large R wave. While the inferior leads, they show RS. R is an upward, S is a downward. So in anterior block, the inferior leads, they show downward complexes predominantly, while lateral leads, they show predominantly upward complexes. Clear? You have to remember this. Right axis, जो posterior hemiblock है, उसमें इसके उल्टा होता है बिल्कुल. Exactly opposite to this. So in left axis, left-sided leads, they show dominant upward complexes, while inferior leads, they show downward complexes. Prolonged R wave, peak time in AVL of greater than 5 milliseconds. So isko bhul jaye, just forget about it. Just remember these two. The lateral leads, they show upward complexes, while inferior leads, they show downward complexes. And this is one downward AVF, which tells you there is left axis deviation. While posterior hemiblock, you've got right axis deviation. So lateral leads show down complex. There is a predominant S wave, while the inferior leads, they show predominant upward complexes. There is predominant R wave. So in anterior hemiblock, there is left axis shift. The lateral leads, they show upward complexes. The inferior leads, they show downward complexes. While posterior hemiblock, there is right axis deviation. There is the lateral leads, they show down complexes, and inferior leads, they show upward complexes. And then you got another situation which is a little more confusing. Bifascicular block. Bifascicular block means there is right bundle branch block with one fascicle blocked, either anterior fascicle or posterior fascicle. This is called bifascicular block. Bifascicular block does not mean the left bundle and right bundle block, because if there is right and left bundle block together, what does that mean? That is equivalent to complete block. If the conduction system in the left bundle and the right bundle is blocked, it means that no wave is being conducted beyond this conduction defect. That means the dissociation between vessels and portions of the ventricle is present. So the bifascicular block means there is right bundle branch block. Left bundle branch is not completely blocked. One of the fascicle is blocked. So you can have right bundle branch block with left axis deviation in anterior fascicle block and right axis deviation in posterior fascicle block. If you have got right bundle branch block and there is left axis shift, this is left anterior hem block with right bundle branch block. And there is posterior block, this is right axis deviation. So you remember this. I think you feel a little confused. Yeah. We repeat it again. Bifascicular block means there is right bundle branch block along with one of the fascicles of the left bundle. One fascicle is intact, the other one is blocked. So it can be an anterior block or it can be a posterior fascicle block. So anterior fascicle block presents with left axis shift and the posterior block presents with right axis shift. For example, we see in this ECG. Now you see this is lead V1. It is showing broad upward complex. It means right bundle branch is blocked. So there is right bundle branch block present. And now we come to these limb leads. We see lead 1 is directed downward while lead AVF is upward. If you remember from yesterday, you see right axis deviation is when lead 1 is negative, AVF is positive. So this patient has right axis deviation. This means posterior fascicle is blocked, not the anterior fascicle. Now, what investigation would you go for? You see electrolytes, arterial blood gases. You go for drug screen. Generally, the drugs are available. Information is available on history, cardiac biomarkers, thyroid studies, CT disorders. So, do you really need to have drug levels in patients who present with heart block? Do you really need this? Haven't you seen Bond series? Go see which one? Okay, you see the Bond movies. Which one is considered happening behind you? Which movie shows this problem? इतना याद नहीं है. क्वांटम ऑफ सोलेस से पहले कौन सी आई थी? मुझे उसका नाम याद नहीं आ रहा है. कैसीनो रॉयल. वो गाड़ी में अपने आप को झटका मारता है कि नहीं मारता? What that? Digitalis toxicity. So there's a digitalis in his drink. So in such situation, you may need drug levels. Otherwise, you know what the drug patient is taking. Lyme disease evaluation. So these are the lab investigations. And then imaging, you require an ECG, electrophysiological studies, echo to see structural problem, FDG PET scanning. What is this? ये PET scan क्या होता है? Fluorodeoxyglucose PET scanning. ये होता क्या है? What is this? FDG PET scanning. What is actually? What information you get from this? So this FDG, once it gets into the cells, it cannot be metabolized, and the PET scan can detect it. So if you've got a cell which has a high glucose turnover, for example, a malignant cell, or if there is an inflammatory lesion, the consumption of these cells for glucose is more, so more glucose enters these cells, but this FDG cannot be metabolized by the normal hexose pathways. So digest कर सकते, break नहीं कर सकते, so it starts accumulating. So it can tell you where are the lesions where there is high metabolic activity. So the scan can be used for those purposes. बाकी जगहों पे, for example, if you are locating say metastatic deposits, secondary deposits, you can go for a PET scan. We had a patient at Services Hospital which I was not able to find out why the patient is having fever. I got a PET scan and found that there was a high inflammation in his right thigh, and that was the source of his fever, and ultimately that was settled down. MRI, and then what is the treatment? Activity restriction, atropine, isoproteinerol, proteininol vasopressor may be used in short term. And when you find that it's a possibility, or if the pacemaker is immediately not available, you can use these drugs. Correct the reversible factors like electrolytes, abnormalities, acidosis, infection, etc. Then transcutaneous temporary permanent pacing. This may be required in patients who got permanent defects. I remember I had a patient, she was an old lady. She developed a heart block, third degree heart block. She was quite old, I think it was some 80 plus. She was just kept for observation for 3 days. She was on beta blockers, the drugs were metabolized from the system, and the heart started picking up. We did not need to put in a pacemaker. So it's the clinical situation. You first make a diagnosis. What is the diagnosis? What is the clinical situation? And what is the next step required? So that's how you plan uh, these things. I think this is the last slide. The pacemaker can be ventricular or it can be dual chamber. Dual chamber means one electrode is in the atrium, the second one is in the ventricle. So there is sequential activation which is similar to the normal activation of the ventricles. The single chamber ventricular pacemaker does not have this normal physiological functioning, but the dual chamber can mimic normal physiological functioning. So if you've got any questions about this,